so we're almost in the home stretch. Thank you so much for coming today, and then also I'm so excited to have the opportunity to talk to you as well about cardio-oncology. Thank you, Lindsay, for that very nice introduction. So I'm Dr. Lavanya Kondapalli. I'm actually a cardiologist, so potentially the first cardiologist that has spoken today. And today we're going to talk about cardio-oncology. What is it? And really, if you've never heard that phrase before, it's okay. There are cardiologists who don't know that phrase. There are oncologists who don't know that phrase. So you're at the ground. We're all in it together. So this is a phrase. Remember it because it's becoming a thing. Okay. So what is cardio-oncology? So what in the grand scheme, I think of it in a couple of different ways. So one, it's cardiac care that's specific to cancer patients and survivors. It's really a supportive service that we offer during cancer treatment, and then once you're done with the acute cancer treatment, and your treatment is all complete. And then really, and probably the best part of what I do, other than the best part of what I do is take care of patients, but which is what I do every day. But the other aspect of what makes my job really great is it's really very collaborative. So it's really a collaborative effort here between cardiologists and oncologists. And our real goal in the end is to provide exceptional cancer care. And so I'm a cardiologist, I take care of patients' hearts all day long, but I really do talk to oncologists more every day than I do talk to my fellow cardiologists. And so why does it matter, and why is it important, and why is cardio-oncology becoming a new field within cardiology? And it's really the truth of the matter is that heart disease is still the most common condition in the United States. So this data is actually from 2012, so a little bit old, but at that time in 2012 it was estimated 26.5 million Americans have heart disease. What is heart disease? Heart disease means high blood pressure, high cholesterol. If you've ever had a heart attack, if you've ever had heart failure, if you've ever had any particular heart condition, like you had high blood pressure when you were pregnant, that all counts as having heart disease. And on top of that, we know that 13 million Americans in 2012 had cancer as well. And cardio-oncology really is right in the middle. So we're the mix between the folks who've got any sort of heart disease and any sort of cancer or a survivor of cancer. And why does heart disease matter? So this is actually from 2008, and this is still true now, that heart disease is the #1 thing that kills Americans for both men and women. It's not breast cancer, it's not colon cancer, it's not prostate cancer. And so what we think about as cardio-oncologists is we are constantly thinking about your heart. We're thinking about your heart before, if you ever get diagnosed with cancer. We think about your heart before. We think about your heart once you get diagnosed with cancer. And when you're going through treatment, I'm still thinking about your heart. And then once we get you through treatment, we continue to think about your heart. Heart disease is something that we can prevent, and so we try really hard within cardio-oncology to do everything we can to be proactive about managing your heart through treatment. And this is also, I bring this up too, because a lot of people don't know what the red dress is about. And so the red dress is really actually a national campaign through the American Heart Association addressing the fact that heart disease is the #1 killer in the United States among women. So here's just kind of the bit of a headline. So, unfortunately, if any of you have ever been consented for chemotherapy or for treatment, that can be a really hard, it's a hard appointment for everybody. You've been diagnosed, you're starting treatment, and the goal is really to start treatment as soon as we think we possibly can. And at that time, there's a lot of consents, and you kind of sign a bunch of stuff, and you just got to get started. And there's when are we going to get the port, and when are we going to get this and that and everything else. And so the truth of the matter is that a lot of the chemotherapy that is changing our treatment of cancers that me and Dr. Corbin and Dr. Davis learned about in med school, now, we thought 6 months. If you've got X cancer, we can give you 6 months. That's what I learned in medical school. But now, thanks to so many advances in cancer treatment, that is not the case. And we have so many new agents, and so people are surviving their cancer, and perhaps they start to fail one chemotherapy, but there's another chemotherapy option. And with all of this amazing research and new drugs in cancer therapy, what we've learned is that some of them have cardiac side effects. And so these are all really common chemotherapies that if you ever go through cancer treatment, you may have been exposed to. And not every patient who ever gets this chemotherapy is going to get a cardiac side effect. but a small percentage will. And if you're in that small percentage, it can be a really important cardiac side effect. In certain places, if you were to develop a cardiac side effect, depending on where you're getting treated, they may say, oh, we got to switch your chemo and that's it. And one of the great things that that I get to do every day is that when we come across these kinds of side effects here, it's really a conversation about, I can manage cardiac problems. I mean, that's the one great thing about being a cardiologist is that a lot of cardiac conditions are treatable. And so with a lot of back and forth between the cardiologist and the oncologist, we can often treat a lot of the cardiac side effects that come up during treatment so that patients don't have to stop because they've developed a potential cardiac side effect. So this is associated with common chemo. You can get some cardiac side effects. Again, not everybody, but just some. And then also too, radiation, which is often a complementary or the primary treatment for some cancers as well, can have cardiac side effects. Now, if you get radiated in your leg, are you going to get a cardiac side effect? Probably not. But a lot of any sort of chest radiation can have cardiac side effects. Most significantly, also radiation to the neck can affect some of the major vessels that affect your heart as well. And so we do care about any radiation that kind of goes anywhere from kind of your chin to your belly button. That your heart sits right in that area and can be exposed through association. Now, I will say that radiation now is different than radiation 30 years ago. And so when we talk about the different complications, and I've given you a list here of all sorts of different stuff, and what does it mean? Atherosclerosis, that just means plaque in the arteries of your heart. Cardiomyopathy means that your heart muscle, which Dr. Hayward talked a lot about, has some changes. Either it stops, it gets a little bit stiffer, or it pumps less well. Conduction disease is things that affect every heartbeat you have is controlled by an electrical wiring in your heart. And this, for example, is radiation changes. This is the aortic valve, which is the last valve. Your heart is like a house, and so your heart has doors that control how the blood moves through the heart. And the aortic valve is the last valve or door that the blood sees in the heart before it pumps to your body. And this was a patient I took care of who was a tennis player, who's a survivor of childhood cancer, and just started noticing her tennis game wasn't as good. And it just turned out that her aortic valve, because of the radiation that she had had when she was a child, had gotten really, really narrow. So your aortic valve, really when it opens, it should be a big black hole, so the blood can just move through. This is an echo image of her heart. And this was her valve open. So she had like a little bit of a pinhole, but all that blood was pushing through when her valve was open. And so these are kind of radiation changes that can happen to the heart. Again, not everybody is going to get these, but some people will, and also sometimes with the chemotherapy that you get exposed to, you're more likely to get these kinds of changes. And then in terms of kind of how are we thinking about this on a global cardiology perspective? So when we think about, cardiologists really care a lot about prevention, and we try to prevent heart disease, right? We try in any way we can. And so cardiologists in general as well are now realizing that we've got to think about chemotherapy and radiation differently. And when we think about, we used to consider stages of heart failure. So heart failure means heart weakening. Your heart's a muscle just like your arm is a muscle. And so when you get heart failure, either your heart muscle gets too stiff or your heart muscle, and so every time that it fills with blood, it's too stiff. Or what happens is your heart muscle pumping function gets a little bit weaker. So to give you a sense of that, every time your heart beats normally, about 55% of the blood in your heart is supposed to pump forward. What can happen with chemotherapy is that sometimes that pumping function can go down. So that every time your heart beats, only maybe about 30% of blood moves forward. We've changed our mindset a little bit within cardiology, so now we no longer think about things as you have your stage 1 when you actually have the condition. We're now thinking about stage 1 or stage A heart failure as being at risk for that condition. So the things that put you at risk, for example, for heart failure include things like diabetes, having a prior heart attack, having high blood pressure, being obese, the metabolic syndrome. These are all things that kind of put you at risk for having heart failure. And a big achievement in cardio-oncology was that we also got the American Heart Association, the American College of Cardiology to realize, hey look, if you've been exposed to a cardiotoxin, we need every person who sees that patient to think of it differently, because that is a risk factor. That's a risk factor just as much as having high blood pressure or obesity or diabetes. And so just So our thought is changing. It took us a long time to get here, but we are changing the way we think about it. And as with time, we're going to have better strategies for prevention as well. And so just to kind of give you a little bit of a sampling of who are the patients that we see in clinic and kind of what do we do on a day-to-day basis, here's a couple of different options. And these are literally patients that I've probably seen all within the last 2 weeks. So one was a patient, so Fred had a heart attack last year. And heart attacks happen, and thankfully because cardiology has kind of been so progressive in the 90s, you know, people survive their heart attacks now. So Fred had a heart attack last year and then newly got diagnosed with lung cancer. For that lung cancer, he's going to need to have chest radiation as well as chemotherapy. And that's exactly, you know, his heart sits right there. He just had these new stents. How do we kind of manage these two issues? Another patient that I've seen recently, so this was just last week, Anna's a breast cancer patient who developed a weakening in her heart muscle during cancer treatment. And we know that certain therapy, especially with breast cancer, so effective in treating breast cancer. At the same time, has a small but true incidence of heart failure associated with it. Joy is a childhood survivor of lymphoma who wants to get pregnant. And so when she was a child, she had a lot of chemotherapy that could affect her heart as well as radiation. And how do we kind of manage that and the potential changes to her heart as she goes through the big stress of pregnancy. Ed developed an abnormal heart rhythm during his stem cell transplant. So he's a patient who had no cardiac problems ever and then developed this, well, what I know is to be a really common thing during transplant, but of course you can imagine how if you've never had a heart problem and then have to get a stem cell transplant and now suddenly have a heart condition, it can be pretty can be a lot to handle all at once. And then finally, Patricia's a breast cancer survivor who, on top of being now a breast cancer survivor, has a family history of early coronary artery disease. And we know that some of her treatment made her already be at stage A heart failure. And then also she now has this also additional family history. So how do we manage her risk to try to prevent heart disease in her? So that's kind of like what is cardio-oncology. And now just to talk a little bit about survivorship. And when I think about survivorship, there's two forms of survivorship that I do. So I do childhood survivors of cancer, but then the really exciting other aspect of what I do too, and they're great, the childhood survivors of cancer are great, but also the adult survivors of adult cancer. And that's really also a testament to how cancer treatment is changing. And as a whole, how we're all thinking more about survivorship in general. So I think that this has all been kind of hammered into your head by this time today, that the survivorship population is growing, which is so wonderful. And this is a little bit old, but between 2003 and 2009, the 5-year survival rate for adult cancer was almost 70%. And in 2012, the National Cancer Institute estimated that 13.7 million Americans with a history of cancer were alive. That's tremendous. The other thing too is that survivors of childhood cancer actually have even greater survival rates. So what we see in our practice is over 80% of children with cancer become long-term survivors. So if any of you are a childhood survivor of cancer, or have children who are survivors of cancer, or have friends or family who are survivors of cancer, we are realizing too that we need to really start paying attention and assessing cardiac risk in the childhood survivors of cancer, because there's so many of them, but they again have been exposed to this chemotherapy or radiation that could have heart side effects. And with regards to kind of what are we thinking about for adult survivors of adult cancer, this is really something that we are just trying to get our minds around and kind of think about what is best practice. We usually have a lot of data on everything we do in cardiology, and in this population in particular, we don't. So we're now in the active process of tracking patients who are survivors of adult cancer. This is one approach to what we consider doing in survivors, and I not just do this for breast cancer survivors, but all of my adult survivors of cancer. We really focus on their preventative cardiology strategies. So, and this is what we're accomplishing today. Today we're doing awareness of your risk of heart disease, because that's one thing that people don't know about. So we need to kind of help patients understand that there's a risk of heart disease. And then we kind of have we get very aggressive about blood pressure, cholesterol, tobacco, diet and weight management. We think a lot, the dose of chemotherapy and radiation matters a lot, because we know certain things are dose dependent. And then also we get very aggressive about diabetes, exercise programs, that type of thing to try to prevent heart disease. And then finally, I think I'm probably the shortest speaker of the afternoon. So just to talk a little bit about cardio-oncology at the University of Colorado and what we're doing here at this medical campus. And really this is actually our mission, and so I'm sharing this with you, but really it's to manage any cardiac issue that arises in patients undergoing anti-cancer treatment and in survivors of childhood and adult cancer. And in doing so, kind of inform evidence-based guidelines in this very underrepresented group. And I don't mean to say underrepresented to be, it's just to be very honest. And the reason why cardio-oncology attracts or is focused on patients who are underrepresented is because big cardiology trials have for years always excluded anybody with a cancer diagnosis. And oftentimes for the cancer trials, if you have any sort of cardiac history, that can also be exclusionary to you as well. And so we're really now at the forefront of, within our practice, we track all of our patients, and we're really trying to inform the research and the guidelines for the next 10 years of what to be doing to appropriately manage patients who have a history of heart disease and a history of cancer, and try to figure out what is our best practice. And then finally, we have a lot of clinics. So we have clinics. I have clinics both in cardiology, and I have a clinic at the Cancer Center. Again, just showing how we're kind of integrated in both fields. The other thing as well here, which to also share with you if you're a survivor of childhood cancer or have friends who are, is that here we also have a Thriving After Cancer Treatment is Complete. So it's called TACTIC, and that's actually a multidisciplinary clinic in which we take care of adults who are childhood survivors of cancer. And we're trying to, again, really attack the risk associated with being exposed to cardiotoxicity as a child. And then those are phone numbers if anyone would like to call. So key points, and I'll take your question. So key points, cardio-oncology is really a supportive service, both during cancer treatment and after treatment is complete. It's in cardio-oncology is a field in cardiology that's focused on managing cardiac issues in cancer patients and survivors, any cardiac issue that arises. And I think really this is a very important take-home, is that some highly effective cancer treatment has cardiac side effects. Most patients do not get those cardiac side effects. But if you do, we're here to help. And the other thing as well is that we are all attuned to knowing which chemo can have some cardiac side effects. So honestly, the oncologists are the first ones who pick up on it. They are very attuned to picking up on any possible potential thing that we need to worry about from a heart standpoint. And then also, cardio-oncology here is really a collaboration between cardiology and oncology. And the focus of our practice is to get you through treatment. So if you are someone who's actively going through cancer treatment, my job as a cardio-oncologist is to work with the oncologist to get you the best treatment you can from a cancer standpoint, to treat that, and just manage anything that comes up with the heart. Thank you very much, and I'll take your question.
Comment on the correlation between thyroid cancer, synthroid drug, and SVT?
And SVT. So maybe Lindsay would be. So thyroid cancer, synthroid drug, and SVT. So a couple of things, and I don't exactly know of any absolute combination. So, but your thyroid is really important in kind of managing your overall physiologic state. And it's not a guarantee that if you have thyroid cancer, you're going to get SVT. But if your thyroid is out of whack, so SVT for everybody is one of the heart rhythms that your heart can go into. It's called supraventricular tachycardia. And basically your heart's, I love the heart, I think it's a really amazing organ, and it's like a house, but it has an electrical wiring system, just like your heart. Your house has an electrical wiring system. So what can happen when you develop any sort of a rhythm like supraventricular tachycardia is that you have a circuit that's in your heart, and that circuit just starts to outpace the normal pacemaker of your heart, which is the sinus node. And so that circuit has the opportunity to conduct electricity and manage every heartbeat, so you get a very fast heartbeat. Supraventricular tachycardia in general can happen for a lot of different reasons. It can happen to people under high stress. It can happen to people under, if you're anemic, all sorts of different things. If your thyroid is out of line, just a little bit, if your function is just a little bit one way or the other, that can also put you more likely to develop supraventricular tachycardia. So if that were to happen, one of the things that we usually do is we like to try to get the thyroid under control, and then that over time can actually help reduce the episodes of supraventricular tachycardia. Many types of supraventricular tachycardia are very treatable with both medicines, cardiac medicines, as well as procedures called ablations. Does that help? Okay. And sometimes that's only temporary, just as you're going through treatment, and then it all gets better once you're done.
I was going to say it's usually with hyperthyroid or Graves' disease, so hypothyroid doesn't treat.
Hypothyroid can cause other types of arrhythmias that are also considered supraventricular tachycardia, but different types. So there's like atrial fibrillation and those, and so I don't know exactly which type you have, so that's why I kind of said both sides. Because it all depends on the type of the tachycardia. Okay, well thank you very much. I'll be around if anyone has other questions.